everyone, let's just start with the basic of the pharmacology, basic of blood pharmacology. So basically we will see what does it mean by hematology. See, hemat means blood and logy means study of the blood. So we will just gonna cover up in this video the basic of the blood pharmacology. Now let's begin. So first we will talk about the iron. Iron is very important. Let's first see the daily requirement of iron. So the daily requirement of iron is, for like adult, it will be around 1 mg, and if there is like a menstruation female, or like the female is having periods, then that will be like approximately we can say 2 mg, and if there is pregnant female, then it will be approximately 3 to 5 mg. Okay, so that is the basic or normal requirement of the iron. So basically the iron is used for the treatment of, for example, if there is iron deficiency anemia, or if the female is pregnant. Okay, and what else, if there is worm infestations. Infestations means when someone is having worms. Okay, so those worms, what they will do, like they will suck our blood from our intestine. Okay, so that's how we can get this iron deficiency. So for them also we are giving. And another case is, for example, menorrhagia, when the female is having heavy menstruations. Okay, now how this iron is absorbed? Okay, we know that there is iron and our body needed it, but the iron is absorbed in certain forms. There is only one form that iron is getting absorbed in, that is in ferrous form. This is, in this form, the iron is getting absorbed from the duodenum. Okay, from what? From duodenum. Okay, and what else is there? That's why in this form only we made one drug, that is the ferrous sulfate. Okay, and we give it orally so that it can get absorbed in the from the duodenum. Okay, so that's why. Another thing about the iron is that the stored form of iron, if we say the stored form of iron, so stored form iron is what? It is ferric. Okay, the stored form of iron is ferric. And one another thing, that if we want to increase the iron absorption, we should give it with the vitamin C, that means ascorbic acid, because that will help, like really help in iron getting betterly absorbed. Also there is like HCl, which like already present, like there is gastric acid, and amino acids also help them increasing the absorption of the iron. Now there are certain substances which decrease the iron absorption also, like for example tetracycline antibiotics. These are like really decreasing the iron absorption, or any alkalis. Why the alkalis? Because these alkalis, they will convert the Fe2 into Fe3. That's why they decrease the absorption of the iron. Okay, now one another thing is that, suppose the patient came and the patient is having this anemia, right? Iron deficiency anemia. So but the problem is with that, the patient is having inflammatory bowel disease also. That time we can't give iron, because iron will upset our stomach, right? So that time what we can do, we can give parenterally iron. Okay, for example, we can give number 1, we can use iron dextran, or like number 2, we can give the iron polyglucose sorbitol carboxyethyl ester. Okay, that we can give. Okay, these two are used when the oral therapy is not tolerated, for example in case of inflammatory bowel disease. Okay, another thing is that, okay, we know that we are giving iron at parenteral route. Okay, for example here, but from which, IV or IM? So we should always give the iron from the IM route, that means from the intramuscular route. Okay, intramuscular injection. And also one another thing is that we should give in the Z technique form. Otherwise, if we are not giving this iron, when we are giving intramuscularly, we are not giving in this zigzag form, what will happen, that if you are giving just to a particular point, then what will happen, then there will be blackening or at that area. Okay, so that's why we should avoid it, giving in just straight form. We have to give it in zigzag form. Okay, in Z form, like this. Okay, So that's what we have to remember. And the side effect, one of the side effect I have already told you, that the oral iron upset the GIT. Okay, so there will be GIT symptoms. There can be epigastric pain. Okay, there can be epigastric pain, there can be nausea, vomiting, and also there can be metallic taste. Okay, there can be what, there can be metallic taste. Okay, then what, these are for like oral iron side effect. What about the parental iron side effect? So the parental iron side effects are like, for example, I have already told, okay, that there can be, number one, there can be blackening and all. Okay, and but if you'll give in Z, like Z technique, from Z technique, then it will be like much better. Okay, so another thing is that there will be pain, but the pain will be at the site of injection where we have injected it. Okay, there will be pain. Okay, now another thing is that, for example, a patient present with the acute iron poisoning. Okay, so the patient is presenting with acute iron poisoning, then we can give to the patient iron chelating agents. For example, that is desferoxamine. Okay, we can give desferoxamine intramuscularly, because we know that the patient is presenting with acute iron poisoning, so definitely we have to give like IM. So that is desferoxamine we are giving. Now, for example, suppose a patient is on chronic iron poisoning. Okay, so what does it even mean? I mean, how it's possible? Yeah, it's definitely possible. For example, if the patient is suffering from thalassemia, so in thalassemia condition, we have to give blood transfusion again and again to the patient for saving the patient life. So if you are blood transfusing again and again, don't you think we are transfusing in a way iron again and again? So that's how the chronic iron poisoning will be there, right? So in that case, we can use desferoxamine again, and we can, and in resistance cases, we can use what, we can use this like deferipron. Okay, in resistance cases we can use deferipron. Okay, that is at the oral form. Okay, now another thing is this was about the iron. Now let's talk about another one, that is about folic acid. So see, folic acid, like it's present mostly in leafy vegetables, and one more thing, it is getting absorbed by the jejunum. Right, it is getting absorbed by the jejunum. The normal requirement is 400 to 500 mcg per day for a pregnant lady. Okay, where we are using this folic acid, we are using in case of the megaloblastic anemia. Okay, we are using in megaloblastic anemia, and to prevent the neural tube defect, we are using this folic acid. Okay, so we need to remember these things. Okay, what else is there? For example, the folic acid which comes today is like leucovorin. Sorry, this leucovorin is another term. Okay, it's, the term is different from the folic acid. Okay, the leucovorin, but it's like the naming is similar, that's why I'm informing you. The leucovorin is actually the folinic acid, it's folinic acid. Okay, and these are used in case of methotrexate poisoning. These are used in case of methotrexate poisoning. Okay, let me write it properly, that is methotrexate poisoning. Okay, these are used in case of this. Leucovorin is a folinic acid which is used in case of methotrexate poisoning. Okay, another is vitamin B12. See, vitamin B12, we also say it's cyacobalamine, right? These are also found in like veg source, for example legumes, or animal source like for example liver, kidney, meat and cheese. Okay, the site of absorption here is ileum. Okay, and basically we use this like vitamin B12 for the treatment of pernicious anemia, or in case of like a gastrectomy, when we cut the stomach of the patient. Okay, for reducing the size of it and all. Okay, that concept. Okay, then also we are going to use this vitamin B12. Okay, vitamin B12 is given from the IM route, or we can give also from the subcutaneous route. Okay, and orally for other like for example, if there is intrinsic factor deficiency, then we can give vitamin B12 orally also. Okay, and now let's talk about certain growth factors which require, like for example here, certain growth factors which require for the formation of the blood. Okay, for example, for RBC we require erythropoietin, which basically is secreted by the kidney. Okay, so if the patient is having anemia and the patient is having kidney problem, then definitely there will be anemia, right? If the patient is like chronic renal failure stage, then definitely there will be anemia. For example, in case of while the patient or for example the patient is on chemotherapy, then also, so in certain case we will gonna use this erythropoietin for the formation of this RBC. One such example is, for example, like peglimestide. Okay, this is for the treatment of the anemia which is associated with the chronic renal failure. For the treatment of anemia associated with the chronic renal failure, we're gonna use this it is peglimestide. Okay, then the side effect of this erythropoietin or epopoietin therapy is that there can be polycythemia. Okay, polycythemia means like there is like more cells. Okay, like more cells. Okay, so like multiple formation of the cells. Okay, and because of this one, so many RBC, so many cells, what there will be, like the blood will put more pressure to flow through this vessel. So what will happen, there will be more hypertension, more pressure, more hypertension, so there will be hypertension also. So that is the side effect of this like erythropoietin. Now the second, for the platelet formation, the growth factor will be thrombopoietin and as well as intrinsic factor. Okay, and where we will use this like thrombopoietin, this growth factor and intrinsic factor, where we will use, where there will be the shortage of the platelet. So we will gonna use in case of thrombocytopenia, that means when there is shortage of the platelet, when there is deficiency of the platelets, then we're gonna use it. Okay, for example, due to the anti-cancer drugs, or for example maybe there is like another condition like there is like immune thrombocytopenic purpura. Okay, when the immune system is attacking the platelets. Okay, and there is like bleeding spot all over the body, that time also the platelet is less, so then that time also you can give this thrombopoietin. Okay, another thing is that there is like this one, this is like oprelvecin, it is a recombinant of interleukin 11. Okay, then what else, there is RBC also, for example like this one, sorry, there is WBC also. So WBC growth factor is like granulocyte like clone stimulating factor, or there can be like granulocyte monocyte clone stimulating factor. Okay, so these are, so basically there is recombinant drug. For example, for this one that will be leno as well as filgrastim. Okay, and for this one there will be what, there will be mol as well as sargramostim. Okay, these are the agents which are used in the treatment of what, in the treatment of leukopenia. Okay, when there is cancer and the patient is on chemotherapy, so it might possible that there is what, there is leukopenia, means there is deficiency of the blood vessel, WBC. Okay, leuco means WBC and penia means deficiency or decrease. Okay, so that in that condition we will gonna give these factors to increase the WBC. So that's all. Thank you for continuing further about pharmacology of this hematology portion. We will cover it in another video. This video was only for the like basic of blood pharmacology. I mean, at least we should know this basic, this is very important.